You're listening to continuing coverage of the Abby Zwerner civil trial from the Hidden Killers podcast and True Crime Today.
You may be seated.
All right, anything to take up before we bring the jury back? All right, very well. Bring in the jury. Folks, I think we're going to hear from one more witness, then we'll take our lunch break, and then we will proceed with the afternoon after that. All right, call your next witness, please.
It's Dr. Munn.
I can get you stand right here, face the clerk, raise your right hand.
Do you swear that the testimony that you're about to give will be the truth, the whole truth, and nothing but the truth, so help you God?
I do.
Please have a seat.
Watch your stepping up.
You may proceed.
Thank you. And can you please state your name for the jury?
Daniel Munn.
And tell the jury, how are you currently employed?
I'm the chief of surgery at Riverside Regional Medical Center.
And how long have you been in that position?
About 10 years as the chief of surgery.
And were you there in that capacity on January 6, 2023?
I was.
Okay. And before we get to that date, can you briefly tell the jury about your medical background, your educational background, I should say, so the jury can understand a little more about you?
Sure. I'm a general surgeon by training and specialize in trauma surgery and surgical critical care. I'm the chief of trauma at Riverside and have been there for 14 years total. I was in the military before that. That's where I trained to be a trauma surgeon in the Navy.
And where did you go to school?
To Wake Forest.
Okay. And after Wake Forest, were you there for all of your education?
Yes, for undergrad, graduate school, and medical school.
And since that date, have you worked in the medical field?
Yes.
And do you have a specialty?
Yes, trauma surgery.
And can you explain to the jury what exactly that means?
So of the general surgery subspecialties, general surgery includes basically abdominal surgery, breast surgery, skin cancer, things like that. And trauma surgery focuses on pretty much the rest of the life-threatening injuries in the body, but we take care of all injured patients. So it might be car accidents, gunshot wounds, stabbings, things like that. Even falls from standing, falls downstairs, things like that.
And Your Honor, at this time I would like to tender Dr. Munn as an expert in the field of trauma surgery, general surgery, and surgical critical care.
Any objections?
No objection, Your Honor.
All right, so qualified.
Thank you. Now I would like to turn your attention to January 6, 2023, and the couple days thereafter. Do you work with a team of doctors?
Yes, we have 6 trauma surgeons and 3, nurse practitioners basically that work with our team. And so I think Dr. Chapp has already testified, but he was the primary surgeon on for trauma at that time. And then the rest of our team were taking care of her the rest of the time that she was in the hospital.
And when you're saying taking care, I should make it clear in the record, you're referring to Abigail Zwerner, correct?
Yes, exactly.
Okay. And you see her in the courtroom today?
I do.
And can you tell the jury, when did you care for her that week that she was in the hospital?
I would have to look at the record to see exactly when we crossed paths, but basically we all work as a team and cover all of the patients in our, on our service. So.
And so what was your role that week when you saw her?
Just supportive care, managing her, all of her medical issues, managing her critical care. She had a chest tube that we had to take care of, and that is a big part of the focus for our team. But all of her injuries are under our, we were the attending surgeons for her and the primary physicians for her, so we took care of all of her medical needs while she was in the hospital.
And just to help you as you're walking the jury through what you did in her injuries, I'd like to share, and if I can publish it with the jury, Your Honor, I have shared it with opposing counsel. I don't believe there's an objection. It's going to be a demonstrative exhibit. We'll be referring to it as MV 13.
Any objection as a demonstrative exhibit?
No, Your Honor.
Okay. So just let me explain to you, ladies and gentlemen, demonstrative exhibit is something that you'll be able to see that assists you in understanding the testimony of a witness, but will not be going back with you to the jury room. All right, so if that helps you taking notes or not. Thank you. You may proceed.
Thank you, Your Honor. And with your permission, it can be published?
You may.
Thank you. And Dr. Munn, do you have that on your screen in front of you?
I do, yes.
Okay. And can you walk the jury through what this illustration means to you in regards to Ms. Zwerner?
Absolutely. So if you look at the left side of the drawing, it's basically sort of a mock-up of a person standing up, or maybe laying down, but basically the whole torso. And the 2 cutouts on the right are images that kind of reflect what we would see with a CAT scan. And so the top one is actually her CAT scan, and then the other one on the bottom is sort of a cutout of what it would look like to slice her like a loaf of bread. So in a CAT scan, her head is into the screen above us, and then she's laying on her back, and then her legs would be sticking out of the screen towards you. And so that, as the CT scanner presents images slicing through the body like a loaf of bread all the way from the head down to the feet. And so they're basically referencing back and forth between the left side of the total of her torso and the cutouts on the right are basically showing you where the bullet went in to the left chest. It went through her ribs, which are to the left of that. So if you look at just the upright one on the left, it's probably easier just follow that course of the bullet. Yeah, sorry.
You're welcome to step down if you'd like.
Yes, that would be fine. Sure. Absolutely.
Having him direct them. Ms. Douglas, any objection to having him come down? All right.
So if you would stand here.
Yeah, and just make sure you speak up. All right, thanks.
Oh, okay. It might be easier if I just stand at the screen, if that's okay.
Yes. Okay. Thank you, doctor.
So again, this is the trajectory of the bullet going into the chest, going through one of the ribs, and then through the lung tissue, and then ending up behind the heart, just along the course of where the aorta or the major blood vessel of the whole body is. And so again, when we're looking at this same image with her sliced like a loaf of bread, it kind of goes in through the side of the chest up here, and then ends up behind the heart, which is this area right there. So the big black areas on both sides are the lung tissue, and then all of this is blood that's collected in the chest from where the injury is. Again, the bullet is this super shiny thing with the arrow pointing to it. It is backed by her spine and very close to the aorta, which is the biggest artery in the body. So look at this image, the aorta comes off the top of the heart, it goes down to the lower part of the body, provides all the blood supply to the rest of the body. And so this bullet is positioned, if you look at this glow up here, it's about 2 centimeters from the aorta and abut in her vertebrae spine. So, if you want me to show what 2 centimeters is exactly.
Yes, if you want. Now, Dr. Munn, are you done with those? Do you want to, or I can?
No, I think that is pretty much it. This image here gives you a better view of what the CAT scan shows because it shows the tissue more realistically. And so this is her lung that has collapsed and shrunken down because it has a hole in it. And that hole has bled into her chest and allowed for air and blood to leak out into the space around the lung.
Thank you. And then if you'll have a seat back, we'll continue questions. So can you tell the jury the significance of the blown up image where it shows the bullet 2 centimeters from the aorta?
So there are several things about the way this bullet went in that are life-threatening. Certainly the injury to the lung, where I described that it has collapsed. Any human being can bleed to death from that level of injury to the lung. But again, where this bullet ended up, it went past the heart and just barely missed it. And then also ended up within 2 centimeters of the biggest artery in the entire body, which patients would bleed to death in seconds from an injury to that vessel.
And Your Honor, if I may, I do have a ruler just to show the jury what 2 centimeters looks like. If I could approach just so they could understand the measurement, Your Honor, I'd ask for leeway.
Any objections?
Object to the relevance if this is cumulative at this point anyway.
All right, I'll overrule it. She can show the jury what 2 centimeters looks like.
Thank you, Your
on a
Honor, I
ruler.
appreciate that. The jurors, you can see on here, that is the number 2 right here.
The ruler's not going back with you all.
Bring that back to my chair. And Dr. Munn, you had talked about the lung collapsing. Can you tell the jury a little bit about that injury as well?
So this is something that we commonly treat that is a life-threatening injury, but the treatment doesn't seem that significant because basically the treatment is to put a tube in and re-expand the lung by sucking out the blood and the air that's around the lung. And so we often do not have to do surgery to get into the chest and fix this problem because the body heals very well when we re-expand the lung. But it is still a very significant injury and something that is can oftentimes cause a patient to pass away at the scene where they're injured.
And the lung, when it collapsed, is that actually scarred to her chest? Can you explain that to the jury?
So the way that we get it to heal is by putting that tube in, it creates a scar that causes the lung to re-expand and stay expanded. And so over that healing process, if we took the tube out too early, the lung would collapse again and she would have difficulty breathing and we would have to put another tube in or potentially do surgery.
And so what does that mean for future surgeries?
So now, as a result of the injury and the treatment for that injury, her lung is scarred to the chest wall. And so that means that anytime, if she had any other injury to that side of her chest, or if she needed surgery to that side of her chest for any reason in her lifetime, we would be going through scar tissue to get to whatever that is. So it limits our ability to treat her for other problems that might affect that side of her chest.
And Dr. Munn, where is that bullet that went into her body?
It
Is it
is
still there?
Yes, it's still in her.
And why was the bullet not removed?
So for something like this, it is actually way more dangerous to remove the bullet than it is to leave it in place because all of those structures that I described that it's so close to are very difficult to get to. And so we leave it in place, assuming that it hasn't caused any additional harm at this point now that she's stabilized from it, and hope that it won't cause any further harm going forward.
And are there a lot of other people in situations like that where you can understand what that looks like for her going forward? Or is this a unique injury that you've seen?
Your Honor, object, it's beyond the scope of his records. There's nothing in his designation about this type of testimony.
All right, you have a response?
Your Honor, I will certainly keep it focused on her injury, and he is designated to talk about the injury of the chest and the bullet inside the chest and what that means for her. But I can narrow that question a little bit more, Your Honor, if you'd like.
All right, sustained with leave to re-ask.
Thank you. So, Dr. Munn, where the bullet is in Miss Zwerner, what does that look like for future injuries that she could have or future needs for diagnostic exams?
So there's no way to provide evidence of what could happen over a lifetime, really, because we can't study all of the patients who have projectiles in them. But we know that they typically don't cause harm when they're in a location that is not near something that's moving. But there are certainly events that could cause this bullet to move if she was under a significant impact of some sort. And the thing that we worry about the most really is something like needing diagnostics testing for MRI or something like that, where she has metal in her and an MRI requires using a huge magnet that can cause the metal to move or heat up. And so it would basically prevent her from being able to have an MRI for the rest of her life.
So in the future, if there was a need for a diagnostic testing of some sort, if there was a concern of anything involving breast cancer or things of that nature, is she going to be able to have an MRI?
Your Honor, this is getting far afield of his designation. It's also cumulative. He's already testified to that.
I'm going to overrule it just for this question, but this will be the last question.
Yes, Your Honor.
On
Thank
that
you.
line.
Understood.
It does apply to my specialty as a general surgeon as well. And yes, that for someone her age, a female patient her age, it would be concerning that she might have to have an MRI at some point. The most common reason would be breast cancer, because it's very common in women, but also anything else that might require additional imaging. And also, just if we were concerned about the fragment moving, one of the studies that would help us with that would be an MRI, which we wouldn't use for her.
Okay. Thank you. And you saw her on when she was initially in the hospital, and then you've seen her January 30th of 2023, correct?
Yes.
And then you saw her again February 6th of 2023, correct?
Yes.
Okay. Can you tell the jury, is there any future needs for her to see you? What would that look like in the future if she needed to meet with you? For what reason?
Sure. So the initial follow-up was mostly to examine her for her recovery and make sure she wasn't having any ongoing complications, the most common of which would be pain from her rib fracture, which she did have when I saw her in follow-up. And then again, if there's anything that changes over the course of any period of time, really throughout her life, if she has complications or concerns about her breathing, then she would come to see us for that.
And Dr. Munn, were all of your opinions testified today to a reasonable degree of medical probability?
Yes.
Okay, thank you. And do all of the injuries that you discussed today related to the gunshot on January 6, 2023, the wound to Ms. Zwerner?
Yes.
And are the injuries that she has today, sitting in this courtroom, permanent in nature?
Yes.
Okay. Thank you, doctor. You'll answer any opposing counsel's questions.
Cross-examination.
Just a few questions. Dr. Munn, if the records reflect that you have not seen Ms. Zwerner in over a year, is that consistent with your recollection?
Yes, that's correct.
Okay, thank you. Other questions?
Okay, no further questions. All right, may he be excused to go take care of the citizens of Newport News.
Yes, you may, Your Honor.
All right, thank you for everything you do. All right. All right, is there a witness we can do in about half an hour, or are you ready to do anything else at this point?
No, Your Honor, I think the next one's going to be longer than a half hour.
Okay.
So
All right, you agree with lunch break at this point, Ms. Douglas?
That's fine, Your Honor.
Okay. All right, ladies and gentlemen, we will take our lunch break for the day. We will try to resume testimony at 1 o'clock. All right, thank you. Anything to take up after they leave? No? Okay. May be seated. All right, any matters to take up before we call the next witness?
Yes, Your Honor.
All right.
Your Honor, we're running a little ahead of schedule, so we intend to call Hannah Zwerner at the end of the day, who is an anticipated witness for tomorrow. We notified defense counsel at lunch. If they object, do not want her to be heard today, wish to have her heard tomorrow. It's their objection, I'll let them be heard.
All right.
Your Honor, just in terms of that, we didn't expect her today, so we weren't prepared for her today. But the other issue is she's the one that created the GoFundMe for Ms. Werner, as opposed, in addition to a T-shirt sale fundraiser. And I would like to be able to ask her about that. My understanding from the motion in limine hearing is that the court ruled that we could not ask about amounts, but that we could ask about the creation of fundraisers. So I would like to be able to ask her about that. I think it goes to her bias.
Right, and I ruled on that already, right? Yeah.
You did, but I did not want to run afoul of the court's ruling and cause a motion for a mistrial. But I wanted to make sure, because we discussed the GoFundMe in the context of just the general evidence at trial, and then we also discussed it in the context of the questionnaire, and the court was very careful to word that, so I wanted to make sure.
Yeah, as long as you're in line with what we've talked about
And just
in
don't
order.
mention the amounts
Yeah,
that were
exactly.
created. But I can ask her, did you create a GoFundMe
Yeah,
fund?
absolutely.
Okay. Thank you, Your Honor.
Okay. All right, and I'll permit you to run your case as you see fit, and if we have time today before my normal closing time, then we'll put her on.
Yes, Your Honor.
Okay. All right, call your next witness.
We have Dr. Anderson, who is standing in the hallway.
All right, very good.
Get your jurors in.
Oh, yeah. Who need, I mean,
Please stand for the juror. Nine jurors in the box.
All right, thank you, Deputy. All right, ladies and gentlemen, we are about to begin our afternoon session. All right, please call your next witness.
next witness is Dr. Romney Anderson. Witness has not been sworn in, Your Honor.
I'd like to get you stand right here, face the clerk, raise your right hand.
Do you swear that the testimony that you're about to give will be the truth, the whole truth, and nothing but the truth, so help you God?
Yes, ma'am.
Thank you.
This way.
Have a seat next to me.
Watch your step, stepping up.
Yeah, please, court.
You may begin.
Doctor, could you tell the ladies and gentlemen of the jury your full name, please?
Sir, it's Romney Christian Anderson.
And you are a medical doctor?
Yes, sir.
What is your specialty?
Orthopedic trauma.
I want to go through briefly, if I can, your resume, curriculum vitae, so the jury will understand your expertise, if I could. When did you graduate from med school and from where?
1996 from the Uniformed Services University of the Health Sciences.
I did want to ask one question. You have a Bachelor of Science degree in what?
Nuclear physics.
And then you decided to go to med school after that?
I spent 7 years in the infantry, and then I went to medical school.
All right. Now, I want to talk to you about the different jobs you've held as an orthopedic surgeon. I take it you became board certified in orthopedic surgery at some point in time.
Yes, sir.
And where have you worked in the field of orthopedic surgery?
So once I finished residency, I went to fellowship at the Shock Trauma Center in Baltimore for a year's fellowship in orthopedic trauma. Then I came back to Walter Reed during the war and helped out with the trauma there. During that time, I worked 1 weekend a month up at Shock Trauma, helping them out as well. And then I worked at a number of little various hospitals doing hip fractures and things on the weekends to help them. When I retired from the military about 11 years ago, or 10 and a half years ago, I came down here to Newport News and currently work at the Riverside Regional Medical Center.
Did you become the chairman of the Department of Orthopedic Surgery at Walter Reed National Hospital?
Yes, sir. I did that for the last 6 years I was there.
And are you the chief orthopedic surgeon at Riverside Health System?
I gave that up recently.
But you were
I
chief for how
did-
long?
I did it for a decade, then gave it up.
Have you published in the field of orthopedic and orthopedic trauma?
Yes, sir.
Without going through what appears to be a lengthy resume, could you give the ladies and gentlemen of the jury a rough idea about how many articles you have written, how many chapters of books have you written on orthopedic trauma?
I haven't reviewed that recently, but there's probably 70 to 80 peer-reviewed publications, 10 to 20 book chapters, and then there's some other articles as well, and there's probably 100 total publications.
Have you been working in the field of orthopedic surgery once you started? Basically, once you became chief of Walter Reed, since that time you've been an orthopedic surgeon?
Once I finished my orthopedic fellowship, that's what I did, yes.
And
And during residency, I just did orthopedic surgery.
And you've been in orthopedic surgery, been treating regular patients since that time?
Yes, sir.
Your Honor, at this time, I'd like to tender Dr. Romney Anderson as a specialist in orthopedic trauma.
Any objections?
No objection.
Without objection, so qualified.
Dr. Anderson, I take it you were working at Riverside Hospital when Abigail Zwerner became a patient.
Yes, sir.
And I'm going to try to walk through what you've done with her surgery, but your primary focus, I believe, was on her hand.
Yes, sir.
And when you saw her for the first time, was that on January 6th or on January 3rd?
Can I
Yes, feel free to review any of your medical records or notes. We had, just so you'll understand, Dr. Munn testified, who was the chief trauma surgeon at Riverside, who I know did see her with the other trauma doctor. At some point in time, I believe they testified that orthopedics needed to come in to work on her hand. I'm trying to determine whether you were on January 6th or on January 7th, if you know.
I
Look at your
believe I
records.
saw her in the intensive care unit on the 7th of January.
Now, could you-
The morning of the 7th of January.
Tell the ladies and gentlemen of the jury, if you would please, roughly what did you see for purposes, and I'm going to go general and then I'm going to show you some medical illustrations.
Yes, sir. So it was,
describe it for the jury, please, if you could.
yes, sir. It's a devastating hand injury with a significant amount of bony injury or bone fractures, as well as a number of soft tissue injuries that were associated with that.
When you say soft tissue injuries, just tell the jury what are soft tissues of a hand, not the skin, I take it.
There's skin, muscles, ligaments, joint capsules, nerves, blood vessels.
And have you seen those types of injuries in your past?
Yes, sir. This, we take care of a lot of stuff at Riverside Regional Medical Center, but on if you stratified these in a scale of 1 to 10, this was a more closely associated with a 10 type injury, which we were seeing frequently during the war.
And what war were you treating orthopedic surgeon injuries with bullet wounds?
OEF, OIF, and Iraq and Afghanistan.
All right, I have shown you and shown counsel before some medical illustrations that were based on x-rays as well as surgical reports, and you have seen them, I believe?
Yes, sir.
Without, it's MV1 through MV9. I'm going to show them to you as a group first, and it'll help us move faster. May I approach, Your Honor? You may. Are these the medical illustrations that were shown to you, and do they accurately reflect Abigail Zwerner's injury, and would they help you in trying to describe to the jury your treatment of her?
Yep. Yes, sir. These are the ones I reviewed.
May I have MV1, please?
Now, are these going to be offered into evidence?
These are
Just
for demonstrative purposes
These
only,
are
Your Honor.
demonstrative as well. All right, so they're not going back to the jury room, okay? Any objection, by the way, Ms. Douglas?
Not to the demonstratives.
Okay, thank you.
MV1 can be published for the jury. At some point in time, and I believe it's on your screen as well, Doctor, and at some point in time I might ask you to step over to the screen, but for now, they've got a large screen there. Could you tell the ladies and gentlemen of the jury what the upper left-hand, let's see if I can get this done. Am I doing it right? Hold on one second. What does the, this picture show us of January 6, 23? This is an actual X-ray of Abby's hand, correct?
Yes, sir.
All right, now you'll see where there are lots of white spots here. Could you tell us what they are?
So the things that are bright white, those are more radiodense, and so X-rays don't go through them, as when they show up white. Those are metal fragments of the bone of the bullet. Excuse
So those
me.
are the bullet fragments that struck her in the hand.
Yes, sir.
And all of those white dots are bullet fragments.
The dark or the bright white, the more gray dots are bony fragments.
All right, let me look at, I take it on the bottom left, that's just a side view of the exact same bony fragments and metal fragments.
Yes, sir. A lateral view.
All right, so looking at this picture of January 6, 23, the medical illustration on the right, could you help us distinguish between the bones and the bullets in this diagram?
So the gray items marked as bullet fragments, those are the bullet fragments. The kind of yellowish tan flecks are bony fragments.
I may have trouble because I don't see yellow.
Or it's a gray, tan, whatever. The rest of the bones, like the finger bones, those little fragments that are a little redder down where all the bony breaks are.
Here?
There, that whole region, or if you'd like, I can come point it out.
I'm going to save you because I don't want you jumping back and forth because we have.
But all through that region you just circled were little bony fragments as well as metal fragments.
And what did you do as the orthopedic surgeon for that hand to try to stabilize Abby?
So the initial, when you see an injury of this magnitude, your initial treatment is not to get everything put back together right away, it's to stabilize things. So we brought her to the operating room for an irrigation and debridement. That is just to try and remove any contamination in there to reduce the infection risk over time. And then, as you can see, some of those bones have no stability at all, and some look like they're short. So we needed to bring those out to length and pin them so that when we went back to do definitive fixation, we'd have the bones out to length and they wouldn't be scarred and short.
When you say you lengthen them and then get them ready for, what are you using?
We use K-wires, just the smooth circular wires that you put in with kind of a drill, and then you cut them and bend them.
Now, I know this is surgery that she was undergoing, but you were not at this time fixing her hand for purposes of the things that you needed to do. You were just cleaning it?
Cleaning it and stabilizing it.
All right, describe for the jury, please, if you would, what are the primary injuries that Abby suffered from with initial injury January 6th that is visible, and then I'm going to show you soft tissue diagram next after the hard bone diagram.
So you can see at the base of the thumb, there's a fracture at the base of the thumb. Then if you go to the index finger.
And I take it, if you'll let me guide a little bit, base of the thumb is
right
here.
That's the base of the thumb. You can see there's highly comminuted fractures there. If you move over to the index finger, the base of the metacarpal there, there's no joint surface even left. It's completely gone with a bone void there as well. And then if we go to the middle finger or the long finger, we can see that there's a large bony defect with highly comminuted fracture.
When you say you lengthen it, what do? You just pull it out and then put wire in?
Yes, sir.
All right, let me switch, if I could, to MV2, please. Should be on your screen. Now, these are the soft tissue injuries?
Yes, sir.
All right, and you tell me where you would like me to go so that you can explain to the jury what is the soft tissue injury. Let me start with the bottom, dorsal external appearance. That's the entry wound of the bullet.
Entry and exit, sir.
And let's move to the left. And I know we just looked at the bones of the thumb. If you could walk the jury from the thumb over to the right and tell us what we're looking at.
So let's start on the index finger. We can see that there was a complete rupture of both of those tendons that extend the finger. And that's where
When you say they're ruptured, tell me what's happened to those tendons.
Oh, I'm sorry. This is looking at the palmar. The picture on the left is looking at the palm. And so that...
Facing up towards the face.
Looking at it like this. And so you can see that there's complete ruptures of the tendons of the index finger flexor digitorum superficialis.
You help us with that in terms that we may understand.
Yeah, I'm sorry.
So this is a hand that's looking straight at my face.
The tendons on the palmar side of your finger allow you to flex the fingers. Each finger has 3 separate tendons. One is called the profundus. There's the superficialis, has 2 slips to it. The profundus goes all the way out to the end of the finger, which flexes the deep part of the finger. The superficialis goes around and comes into here, which bends at the, I guess you'd say, like the first knuckle. We could see that the index finger, the one that goes all the way out to the tip, was 25% lacerated.
Which finger?
The index.
Gotcha, second.
And then the flexor digitorum superficialis, 10% lacerated.
All right, now let's go to the far right.
Yes, sir. So this is looking at the hand like this. Looking at the back of your hand like this.
And so her thumb would be on the far right of this right diagram.
Yes, sir.
Tell us what we're looking at.
So the first thing on the top there talks about laceration and contusion of the posterior interosseous nerve. That's a nerve that goes out from your forearm across to the wrist joint, and that's what gives your wrist innervation, or gives you sensation of the wrist.
And what happened to her nerve?
It was transected and contused.
When you say transected, for our
Cut.
purposes,
Cut. Yeah.
Trying to make sure we all understand.
Right.
Keep
So,
on moving, right to left.
And then as we go to the right, we see that there's
To the left.
from the small finger to the thumb, as we
Gotcha.
move from left to right,
All right.
there's a 75% laceration of the finger that, or the tendon that extends your finger independently. So most of your fingers have a common tendon that helps you extend all your fingers at the same time. The index finger has a separate tendon so that you can point. Like, it's very difficult to point with your fourth or middle finger. It's hard to pull that finger up by itself, but you can do it with your index finger because it's got a separate tendon, which is the extensor indicis
What
proprius.
happened to Abby's tendon?
It was 75% transected, which if you don't do anything with it, tends to rupture.
I keep on going. I take it that all these gray things are what?
That's bullet fragments.
I keep on going.
So as we go to the right, we see that there's a tear in the thumb joint capsule at the base of the thumb, and
Is that here?
yes, sir, right about there. And then there's a dorsal retinaculum tear. And so if you take your fingers and you go like this, the retinaculum, if you can see the tendons on the back of my
Can
hand.
you see the back row there? You need to a little bit higher for, and
So the tendons, you can see them kind of on the back of my hand. The retinaculum holds those down tightly here so that they pull the fingers up. If that retinaculum wasn't there, these tendons would do what we call bowstring, and it would try and go from here to here and just lift up and not lift the finger as well. So that retinaculum keeps the tendons in place so that they have a mechanical advantage to extend the fingers. That was torn.
all right, anything else here that needs to be seen?
No, sir.
All right, this is all as of January 6th and 7th of 23, correct?
Yes, sir.
Did you decide and make a plan for surgery?
Yes, sir.
And when were you going to plan to do your first surgery? On the 7th?
We did, well, the first surgery on the 7th was
To do the wires.
to stabilize it. We've already talked about. Yes.
Did you decide when you were looking at Abby's injuries to bring in another doctor to assist you with the surgery that you needed to perform.
Yes, sir.
Who was that doctor?
Dr. Scott Tintle.
And could you tell the jury, please, why he brought the doctor in and where did he come from to assist?
So Dr. Scott Tintle was one of my residents at Walter Reed when I was the chairman there. He had went on to do hand surgery, but he and I did a number of the more difficult hand surgeries at Walter Reed. And so when I was looking at this, I was like, this is much more similar to a war injury than it is what I normally see. And having a second set of competent hands in the operating room is very valuable when you're taking on a problem of this magnitude. So I contacted the administration. They said, be happy to let you bring this guy in. We got him credentialed in a few days, and he came down and helped us with the case.
When did you do your first surgery post-wiring of her hand?
I'm going to refer to my notes here.
And I'll direct you to January 16th of 23, if that will help
Yes,
you.
that's when we did the next surgery. It was the 16th of January.
MV4, please. And feel free to refer to your notes at any time to any of the issues involving.
Yes, sir.
The first issue, I believe, is a left-hand gunshot volar wound. Tell me what that means.
Volar's the inside, dorsum's the backside. So there's gunshot wound there.
All right, let's talk about the frame A of the January 16th, 23, part 1.
Yes, sir.
Tell the jury, please, what we're looking at in A.
So oftentimes people will hear about people that get carpal tunnel syndrome from like typing too much or things like that. That's that this transverse carpal ligament that you can see being cut in this picture is. There's right there, right. You can also get it from traumatic injuries. We knew from the radiographs that there was a large bullet fragment in there, probably irritating the median nerve, so we needed to go get that out.
And so the purpose here is to just remove the bullet fragment.
Remove the bullet fragment, give the median nerve more room to kind of live in a traumatized hand.
All right, let's go up to B, please, and tell the jury what we're looking at here.
So we've just reflected the transverse carpal ligament, and then we remove the bullet fragments in there.
All right, C, please.
So one of the tendons that flexes your finger was lacerated as well, so we repaired that. Flexor did
So where am I looking here? I see that the skin's been pulled back, and then I see a pinching device holding it on the right there.
right where that arrow points is where we repaired the tendon. You can see the little sutures in there.
Right there.
Yeah.
All right, and so what was the primary purpose other than removing of the bullet fragment of the carpal tunnel area?
Make more room for the median nerve and repair the tendon.
All right, let me move to MV5, please. Tell the ladies and gentlemen of the jury, what are we looking at here? And I take it this is also on January 16th, 2023. We are deeper. Am I on the left-hand side? Am I looking at the top of Abby's hand or the underside of her hand?
So the left picture is looking at the back of the hand.
Back of the hand, I'll use that. Tell us what we're looking at here.
So we see that there's more bullet fragments there that we took out.
Which are all in here?
Those little gray things, yes. And then we see the laceration to the tendon that extends your finger independently.
Right there?
Yep. And the picture on the right shows us repairing
Before you get there,
tendon.
that in the middle there, which I'm messing up my little, I'm going to start again. There you go. Those are all bullet fragments that you pulled out of the hand?
Yes, sir.
All right, tell us what we're looking at here on E.
That's just repairing of the tendon that we saw lacerated on the left.
So it calls it the,
Extensor indicis proprius.
right? What is that specifically? Because I'm not sure I heard those terms.
That's the tendon that by itself is responsible for extending the finger so you can extend the index finger independently of the other fingers.
And what are you doing in this surgery here?
Oh, bringing the ends of the tendon back together and sewing them together.
Does scar tissue normally form in those areas?
Frequently.
And does the scar tissue cause problems and or future problems with someone like Abby?
It causes the inability to flex down all the way because the tendons on the back are scarred in. And on the palmar tendons that were repaired, makes it hard to extend the fingers.
Let me move to MV6, please, and tell me what we're doing here.
So
And I'm going to start off at F. We can zero in on F because it's real fast.
So on the back of the hand is where we fixed the index and middle finger metacarpal. This is a picture of fixing the middle finger metacarpal. We put a plate over the area. You can see that there's a large bone void underneath those screws.
So this is a plate, or are those,
That-
what is that? Because I see a screw being put in,
That's a metal plate and metal screws that we're putting in there,
and is that to take the place of the bone that was removed by the bullet?
and to hold it stable, yes,
All right, move to,
to try and help it heal.
obviously it's not a final fix, it's to try to get something.
Yes, sir.
Move to the same picture, but go to G, please.
So in the picture in G shows that we've already fixed the index finger metacarpal.
Point for the jury again which one we're talking about so they can see on your hand where we're talking.
This finger right here.
All right, is this the same plate or a different plate?
That's a different plate. There's two plates in there. You see one kind of hiding out under the tendon on the left side of the screen.
Behind
Yep,
there?
that's one that was on the other image. This one right here is for the index finger, and this one had the index finger where you're pointing right there had such bony destruction it took out the whole joint space of the proximal part of the metacarpal. So the trapezium.
And when you use those terms proximal, could you explain to the jury what we're talking about on a hand? For us.
Closer to the wrist. It took out the whole joint in there, so we had to do a fusion down to the trapezium.
And when you say
Trapezoid.
the bullet just removed the whole bone.
It came out and spit it out across the floor wherever, and it went out when the bullet went in and took bone with it out the backside of the wound.
All right, tell me what we're looking at here.
And this is the thumb where we had to fix the thumb fracture as well.
And again, another plate.
Another plate and screws, yes.
All right, M.
Oh, and we also had to do the joint capsule has gone down there as well, so we had to put in a suture anchor to sew the capsule and ligaments down there.
All right, let me focus you on that for just a second. This is a suture anchor. Where is that going and what is it doing?
It's going down into the capitate, so the tendons that extend your
Gotta
wrist.
help this juror on the far left.
The tendons that come from your arm down to your across your wrist and go into the carpal bones, or those are all the kind of intermediate bones in here that allow you to bring your wrist up. Those had both been completely transected. They're very difficult to sew back into bone, so we put an anchor into the bone and then sew the sutures on the anchor. So if you look at that picture where it says suture anchor, there's some suture there. Down, yep, right there. We take those sutures and tie it into those tendons, so now that when those muscles fire, it brings the wrist up.
Now, in looking at the notes, there appears to be some non-biodegradable drug delivery antibiotic spacers, I believe, what they are.
Yes,
Could you
sir.
tell the jury, please, what the purpose, what are they, what are antibiotic spacers, and what is your purpose of putting them in the hand?
So, when you have an injury this devastating with bone loss, you're going to have to come back later and do a bone grafting procedure. If you let that just all fill in with scar, it doesn't leave a nice pocket to put the bone graft in. And so we put in this, it's bone cement that people use when they get a total knee or a total hip. We fill it full of antibiotics. Those antibiotics leach out over a several-month period of time, so it helps fight infection as well.
So it's basically a time-release capsule that's buried into the hand to let out antibiotics
Yes,
to
sir.
stop an infection. Let me go to MV7, please.
And in that, we put vancomycin, gentamicin, and tobramycin, three pretty hefty antibiotics to try and
Keep the infection from happening.
keep the infection from occurring.
The risk of an infection to Abby at this point in time is,
It can be devastating.
I believe I am on MV8. 7, I mean. Tell us what we're looking at here. This is, I take it, post-operative, so you finished your surgery. I'm going to start with frame I, please.
So the thumb tendon, there's a sheath that thumb tendon runs in, and that was all damaged, so we took it out of the sheath and just moved it over so it wasn't captured in this damaged sheath.
I take it these are all these are what you've placed in there to help with the bones.
Those are the plates for the bones, yes.
And you've moved soft tissue tendons so that they can be free of the damaged area.
Yes, sir.
What is on the far right?
That's just the same thing.
All right, what
So you
it
can
says
see the
here-
incision being made in the extensor pollicis longus tendon sheath on the left, and then
that
it being on your left picture where the knife is.
Okay.
You can see that's taking the sheath that was damaged, opening it up, and then taking the tendon out and moving it over.
And then where is, I'm looking at here, where
It's just a little bit more to the right of the screen than it was on the left.
Gotcha.
You can see the empty sheath behind the tweezers there.
Gotcha.
See that?
Here?
There, go to right behind the tweezers is the empty sheath.
These
Yep,
tweezers or
right
those
there,
tweezers?
right there, yep.
Right there.
And then the tendon is moved over, so it's not in that damaged sheath.
All right, the next part of that slide, please. So tell me what I don't think we need to see it. Well, let's look at Jay real fast.
So when we talked about the tendons having a tendency to bowstring without that retinaculum, we had to repair the retinaculum there.
And that's what you're doing here.
That's what we're doing there, yes, sir.
All right, let me go to the x-ray on this same slide right here. All right, so this is post-surgery, I believe.
Yes, sir.
January 16th, 2023. And you are looking here at all of the hardware that you put in there.
Yes, sir.
Right? Tell me what these, I think I know what they are, but I'd rather you tell me. What is all this kind of reddish area here and around there? What are we looking at there?
Those are fractured bones.
And why are they left there in that kind of condition?
Well, if they've got some soft tissue attachments to them, then they've got a chance of healing in. So it's best not to take out things that you think are viable that can help the bone heal.
All right, I take it you continue to operate and work on her, and I believe your next surgery is on March 16th, which would be MV8.
This is still the same. This is March
still on
16th.
March 16th?
Yes. So
All right, so let's talk about A first. What are we looking at here in the upper left?
it's she had these bone voids in her hand. In order to get bone to fill those gaps, we have to get bone from somewhere. We have to steal from Peter to pay Paul. So we go into the hip where there's good. The bone in the hip has very high amounts of bone growth factors in it. So when we take that type of bone, we get better healing. So that's why we made an incision over the hip, made a little window in that iliac bone, went down and took out a bunch of bone, put it on the back table, and closed the wound.
How do you take the bone off of her left iliac crest?
With chisels and hammers and chisels.
And what are you left with when you do that? Just pieces of...
Well, you leave the soft tissue attached on one side, so it's kind of like a window, and then you bring it back down and sew it into place.
And what are the bone pieces that you've removed? Are they broken bones? Or are they
No, it's
slices?
just
What
it's
are they?
the bone marrow from the inside of the pelvis.
All right, let's move to B, please. All right, so I see here, and so that is the antibiotic spacers that you had placed into the earlier surgery?
Yes, sir. Those
And why
are
are you taking them out now in this date?
So we're taking them out now. Now there's a void there in the ends of the bones, and that's where we pack the bone grafting.
All right, let's move to C, please, of that same. So I see this tube here, the blue arrow, and then I see what looks like something you're about to punch
Just
into
a
that.
little-
That is the bone graft from the hip.
Yes, sir.
And tell the jury, please, what do you do with that bone graft and that tube there?
We just pack it in the void between the two ends of the bone.
And how do you keep it from coming out?
Well, that's what putting the antibiotic spacer in it kind of creates a rind around the edges of it, and it makes a nice void to contain the bone graft.
Now, I don't have graphs to show it, but there appeared to be a third surgery in February of 2023 and one on March of 23 that had to do with manipulation. Could you tell the ladies and gentlemen of the jury, what do you do and under what circumstances do you put Abby for those other surgeries?
So when you have bad injuries like this, there's oftentimes a lot of scarring that goes in and around the tendons you've repaired and things. She had kind of hit a plateau with regard to therapy, so we discussed with her and then brought her to the operating room to do what we call a manipulation under anesthesia. So we put the patient to sleep so that they can't feel anything, and then push like crazy to get the joints and the tendons and the loosened up so that we can get better range of motion.
And why do you have to do that under general anesthesia?
You can't tolerate that without anesthesia.
So are you worried about damaging the bone repairs that you've done when you're doing that, or are you just focusing on the manipulation so that there's movement of the hand?
It's a balancing act. You know, certainly if you put too much pressure on it, you could bend one of the plates or break the bone and the plate. So it's, you know, after you've done this a number of times, you get to a point where you feel like I just can't go any farther. But we got good manipulation out of her without breaking any bones.
And how many times in February, March, did you put her under general anesthesia? Twice for purposes of that manipulation?
We did it once, but the second time we did, we were going in to take out the plates and repair a tendon that had started to lag.
What was your plan and what was Abby's duties for purposes of your treatment between that time, February, March, up until October of 2023? What was she supposed to be doing, and was she doing it as far as
she was aggressively working with occupational therapy to work on range of motion and strengthening.
And what's the difference between what they're doing and what you did under general anesthesia, the manual manipulation?
It's similar. We know that the scar tissue fails by what we call fatigue failure. In other words, if you take a paper clip and bend it once really hard, you're unlikely to break it. But if you sit there and just bend it back and forth, back and forth, back and forth, ultimately that paper clip will break. The scar tissue does the same things. The more you can get them to move, and frequently I'll tell patients with this type of problem, you know, you're reading a book, watching TV, I just want you to move and move and move and move. The more they're moving, the better they have of breaking up that scar tissue.
Now, my memory from looking at the surgery from this March 16th, there was something regarding the tendon itself pulling apart. Do you remember that?
Yes. So
tell the jury what that means and what it meant for Abby.
So Abby, the tendon that extends your fingers to be able to bring them up, the tendon to the middle finger had done what we call attenuated. In other words, a tendon has got a bunch of collagen fibers that are all hooked together. It had slowly pulled apart and was longer. So when Abby would try and raise all of her fingers, there would be a sag in the middle finger. So what we did is when we went in to take out the plates, we brought that tendon kind of back together, and we call plicate it, trying to bring it back, shorten it up a little bit, and then tie it to some other tendons that have the same function to give her a little better extension of that middle finger.
I take it she's not healed at this point in time, but you are still in the process of getting her better and better as best you could.
So Abby's hand is never going to be a normal hand. It's not going to be like her other side. But we've got it pretty darn close, and a lot of it's attributed to how hard she worked with therapy to do that. I mean, you can do a perfect surgery. If the patient doesn't do any therapy, they're not going to get a good outcome. So she's done a lot of work. I think she's done remarkably well with the number of injuries she's had there, but it's never going to be a normal hand.
I take it you did surgery again in October 2023?
I think that's the one where we took.
And that would be MV9?
That's the one where we found the adhesions.
It's on your TV screen, I believe.
Oh, yeah, that's
Demonstration.
that's the one where we took out all the plates and did the tendon work for the lagging tendon.
All right, so in A, as I'm looking here, all of these plates have been put aside. And are you in the process of taking out the plate on the right?
Yes, sir.
All right, tell me why you're taking out that plate and what's that leave for purposes of her bones?
So, if you've got a plate on a bone, and you can imagine this tendon riding back and forth over top of that bone over time, they can rupture. And there's a lot of stuff in there. Those that were sitting right over the tendon repairs. So it made sense to take out the plates at that point in time, especially when we were going to go ahead and do the plication of the tendon.
All right, let's look at B. Same section, same slide. I take it this is the thumb plate?
Yes, sir.
And are the same issues of concerning the tendons rubbing against the plate over time?
Yes, sir.
Could you tell the jury, please, what is Abby's hand like now 10 months post-surgery once you've removed these plates? What is the condition of her, the hand?
The bones are still healing. They're not healed up all the way, but we have seen union of the middle finger. But she's still got pain with motion. Still a lot of pain is related to the soft tissues.
All right, so tell me, and I think that you can go back to the main slide there. Is this your last surgery with Abby?
Yes, sir.
23?
Yes, sir.
And when you saw her in 23, how would you describe her condition?
So she was having pain at the base of, kind of in this region right here. It was hard to tell whether that was from the index finger bone not healing all the way, where there was no joint and we had to fuse it back to the trapezoid, or whether it was arthritis in the base of the thumb.
And why couldn't scans, x-rays, MRIs, whatever, why couldn't that tell you?
Well, we did do a CT scan. It showed there was a clear non-union there, but these are, a centimeter apart, and it's difficult to tell on physical exam which was which.
Tell the jury, please, what does non-union of that bone mean in that area?
There's fibrous tissue in there, and it's not bone that's healed all the way across the fracture.
And how would that affect Abby in using or trying to use that hand with regard to pain or discomfort when there's a non-union of a joint?
When we tend to have non-unions, it's painful. Moving things with non-unions causes just a tiny bit of motion at that area, and the tissue around the area is what causes the pain. And so anytime you'd use that, you'd feel some pain.
Now, did you decide to do something with regard to this area of her body with regard to a future surgery?
So I would have been happy to just bone graft the non-union. However, I don't do base of the thumb arthritis surgery. That's really a surgery that's done by hand surgeons for arthritic conditions, just like a joint surgeon does knees and hips, a hand surgeon does base of the thumb arthritis. So at that point, I felt that the best thing to do would be to send them to somebody that could treat both of those problems if both of them needed attention.
Once someone went in and opened up the hand, they'd be able to see what the scans may not show and then operate on whether it's arthritis or something else.
Yes, sir.
Did you have a doctor in mind when you did that?
So there's a doctor up in Richmond, Dr. James Stewart, who's widely recognized as he takes on a lot of difficult cases and referrals. And so I called him and said, can you take a look at this and tell me if you think it's the base of the thumb or if it's the index finger non-union? I'm happy to do the index finger non-union, but if it's a base of the thumb arthritis, it's something I'd like to have you take care of.
And as far as you know, he performed that surgery in 25?
Yes, sir.
And you have seen his medical reports since that surgery? Do you know if you did?
I think I've seen, so Abby would come back and follow up with us, so I seen, but I can't recall whether I actually read his op note or not, because I talked with him. I was like, what'd you do?
Right.
So I knew what he did, but I can't remember if I actually read the op report or not.
Now, you already indicated that Abby's hand is never going to be normal,
yes,
like
sir.
her other hand. First of all, let me ask you whether or not all of your opinions today are stated with a reasonable degree of medical probability,
Yes, sir.
and all of your opinions today relate to her being shot on January 6th of 2023, all
Yes, sir.
caused by that.
Yes, sir.
Now, when you say that they're permanent, what sorts of problems is Abby going to have, even understanding that she had surgery in 25 for the thumb? What sort of permanent injuries does she have now and will continue to suffer?
She'll certainly never have the exact same range of motion as the other side, never the same mobility. We fused joints. There's more scar tissue in there than the hand that's not been injured. She'll probably have some component of chronic pain over time.
Does age help or hurt an injury like this?
Being young allows your body to be more resilient than if this had happened to you or I, but certainly a devastating injury is a devastating injury.
What happens when she's 50, 60 years old? What does that do to these injuries?
So she'll be at risk for having some of those tendons rupture as they rub over healed bones and things. Tendons may continue to attenuate. She's had some, color changes to her skin and things based off of probably some of the nerves that were injured in there.
If I could, Your Honor, could I have the doctor just step down and point out to the jury with Abby's hand so the jury can understand where the surgery is and what's left, and how it looks now and why does it look so different?
Any objection to that?
No objection, Your Honor.
All right. Be careful stepping down.
Abby, could you stand up so the doctor
Ms. Douglas, if you wanted to step up, that's fine as well.
The doctor, why don't you do it over here so the jury can see, and I just wanted you to point out what you've done and tell me what the hand.
So when we look at the back of the hand, would you want to come over here? So you can see that there's kind of a little divot in the back of the hand. That's where some of the soft tissue is lost. You can see the entrance and the exit wounds are up here. If I ask her to move the hand dorsally, there's going to be tightness in there. If I ask her to flex it, there's going to be tightness in there. You don't see a lot of color change now, maybe a little bit darker here, but as her nerves fire, they can cause blood vessels to expand or contract, and that somewhat gives her those color changes. Although this is better than it was, the ability to extend that middle finger all the way is not perfect yet. We can make that fix that. And so you do the other side as well. So certainly see that she doesn't have the ability to bring the fingers down all the way. Then you can see on the inside here where we did the surgery there, that's where we do a carpal tunnel surgery and remove that. There's certainly, if you can compare both sides, there's a lot of thickening in there where there's scar tissue. And if you bring your fingers and spread them apart, she doesn't have the muscles that spread your fingers apart are called the interosseous muscles. She's not able to fire her interossei don't bring the fingers all the way apart like she has on the other hand.
What about strength?
Oh, so grab both my fingers here, just grab your hole and squeeze as hard as you can. This side would be considered normal. This is less than half of what I'm feeling on this side, and I think some of the occupational therapy we did some strength testing, but I don't recall exactly what those were.
Sitting here almost 3 years after the shooting, do you believe that she's going to get that range of motion or strength back to any significant degree from where she is today?
She may make some slight improvements, but I don't think she's going to make drastic improvements and have her hand be like the other hand at this point.
Doctor, you can take the stand again. I'm not certain that I have left anything out, but I want to ask before I sit, if I could, for 1 second, Your Honor. Doctor, please answer any questions that counsel may have of you. Thank you very much for your time.
Yes, sir.
You want this?
Oh, no. Dr. Anderson, just a few questions for you.
Yes, ma'am.
So your last surgery was in October of 2023.
Yes, ma'am.
And are you aware that a few months later, Ms. Zwerner started cosmetology school?
Yeah, I didn't know how long after that she started it, but I know that one of my appointments we'd talked about that.
And are you aware that she completed cosmetology school from January 2024 to January 2025?
I did not know that she completed or graduated, but I knew she was in it and
You had no objection to her going to cosmetology
No,
school?
no, ma'am.
And did you, or were you aware that she has become a licensed cosmetologist in the Commonwealth of Virginia?
I did not know that she's become a licensed cosmetologist, but congratulations to her.
Congratulations. And Dr. Anderson, do you, in your course of treating Ms. Werner, do you recall a time where she contacted you and asked you to backtrack and write work notes for the past 2 years?
Yes.
And tell me about that.
This happens all the time in clinic when people have had some injury and now they're looking to get back into doing things, and there's, maybe we didn't do that in the past, and at some point in time when she's not working and we don't give them a work note, we have to go back and amend work notes, not infrequently.
Okay, so you had not done work notes in real time for Ms. Werner for the past 2 years?
And I don't recall, quite frankly. I'd have to go through my notes and say whether or not we did or we didn't. It's not something that I usually do. It's something that when you take care of an injury like this, there's a large number of people that are helping take care of things. We have medical assistants in the clinic that frequently do that stuff for us, and then I'll sign it. But I oftentimes, if we miss it, we have to go back and do it later.
Just asking you, Dr. Anderson, do you recall backtracking a work note?
Yes.
You backtracked a work note?
I know we had to do work notes to make up for time that we didn't have work notes previously.
Thank you, Your Honor. Thank you, Dr. Anderson.
Yes, ma'am.
I promoted you to a judge.
I'm not sure that's a promotion.
You have a nuclear degree. I want to follow up. After you do these different surgeries that we've talked about, what do you do with her hand? Is it wrapped? Is it a cast? What is the condition when she leaves the OR or the hospital?
So usually we put it in with dressings and a splint, and that splint needs to come off fairly quickly, because usually if you left something in a splint for 6 weeks, it's just going to get stiff again. So like when we're doing manipulations under anesthesia and we're trying to get the tendons to move and things, we'll put it into a splint just to let the soft tissues heal, let the wounds heal, and then start range of motion, usually around 2 weeks.
Did you want her to be careful about the use or damage to that hand post-surgery?
Yes, sir.
I have no further questions of this doctor.
Any follow-up based on that?
No, Your Honor.
Dr. Anderson, thank you very much. I appreciate your time.
Is he free to go?
He is free to go.
All right, you are free to go. You're excused from court. Just please don't, because the case is still ongoing, don't talk to anyone about it, okay? All right, thank you, doctor. All right. We are ready for the next witness?
Yes, I'm ready for Dr. Stewart. Jeb Stewart. Witness has not been sworn in.
I'll give you stand right here, face my clerk, raise your right hand.
Do you swear that the testimony that you're about to give will be the truth, the whole truth, and nothing but the truth, so help you God?
I do. All right, this way.
Sit over here, please.
Watch your steps, steady.
Good afternoon, doctor. Could you tell the jury your full name, please?
James Yule Brown Stewart.
And are you an orthopedic surgeon?
Yes.
Dr. Anderson just testified and says you take on all the hard cases.
Challenging.
Could you tell the jury, please, a little bit about your medical education background?
I went to medical school in Norfolk, Eastern Virginia, and Army Scholarship, and trained as a surgery intern in El Paso, Texas, at William Beaumont Army Medical Center, and did my orthopedic surgery residency at Walter Reed Army Medical Center, and subsequent hand surgery fellowship at Walter Reed, and served 4 more years in the Army, retired in 2021, and came to Richmond, Virginia.
How long you've been doing orthopedic surgery?
Since a residency, close to 30 years.
Your Honor, without going through more, I tender the doctor as a specialist orthopedic surgeon.
Any objection?
No objection, Your
All
Honor.
right, thank you. He's qualified as an expert in orthopedic surgery, is that correct?
Dr. Stewart, I'm going to try to narrow your testimony because Dr. Anderson took us all the way up to when he referred Abby to you.
Yes,
And I take it that you took her under your care at the advice and recommendation of Dr. Anderson because of a particular problem with her thumb?
yes.
All right, I'm going to show you, first of all, MV10, which is a medical illustration, which I believe I had sent to you, and asked you if this would help for you to describe to the jury what you did.
Yes.
All right. Your Honor, permission to publish MV10?
Any objection?
No objection.
All right, once again, demonstrative.
Yes, Your Honor.
All right.
It's on your screen, Doctor, and if I can point, and I'm going to look at slide A first. And first of all, as we're looking at A, tell the jury what you found when you went in initially to look at Abby Zwerner's hand. I think you had to open her up besides
Sure.
scans.
Well, what I expected, which was an unhealed bone in her left hand with a defect.
And what kind of defect?
We call it a non-union, where the bone did not heal.
Now, Dr. Anderson had indicated that she was having some pain in that area of the hand, and he wasn't certain whether it was arthritis or it was a non-union or what, which is
Correct.
What is it that you found, and what would you describe the reason that she was having pain in that part of her hand?
My initial evaluation, I was more impressed with the pain in her thumb joint, which is just underneath that device with the bone graft, even though she had movement of the non-union in her left hand. And I tried a cortisone injection to the joint right next to that area to see how she would do for both therapeutic and diagnostic reasons.
And how did that shot help or hurt?
She came and saw me a few months later and said it helped for about a week or two and had moderate relief, but at that time also her complaints and exam findings were more consistent with a symptomatic non-union or the problem there at that metacarpal in her left hand.
Do you know when you first started seeing Abby? Was
Yes.
that the beginning of 25, or when was it?
That was December of 2024.
And
So
is that
almost
when-
2 years from the time of injury.
Gotcha. Is that when Dr. Anderson had referred her to you?
Yes.
All right, so I take it you attempted to perform surgery to try to relieve this pain? Is that what we're looking at in April
Yes.
14th of 25?
This illustration illustrates the surgery that I recommended, which is a repair of the non-union using structural bone graft from her pelvis.
All right, so let's go to B, please. Dr. Anderson had indicated that he had taken a pelvis bone. Did
Yes.
you have to do the same thing?
Yes, from her opposite side.
So you went into the iliac crest of the other side?
Correct.
He described moving or chipping away the bone, putting it
Your Honor, I'm
aside.
just going to object to the leading.
Go ahead and tell us what you did on the iliac crest of the opposite side. I apologize.
Objection is sustained. Now you can answer.
I'm going to rephrase it. You tell us what you did with the iliac crest of the right side.
So this type of problem requires good bone graft, and it's typically from the patient. We call it autogenous. And the iliac crest has probably the highest quality bone graft. And you basically remove a section of bone from the iliac crest or pelvis. And her original bone graft donor site was on the left, so I went on her right side to get that.
And where did you place it?
I placed the bone graft after cleaning up the non-union site in the space, and it measured about 1.5 centimeters or so in length to fill the defect.
And when you say it measured, is that the gap size for the
gap
non-union?
size, once it was cleaned up, the non-union and the devitalized tissue, yes.
All right, so what are you doing here in B of MV10?
You can see the bone graft, that little trapezoidal area of bone at the base of the metacarpal, and then the plate and screws.
right there?
Correct. And the plate and screws are being used to stabilize the bone to allow it to heal.
Now, if my understanding is correct from earlier testimony, Dr. Anderson had a bone graft, a piece of like this before?
I think it was mostly cancellous, but I'd have to go back and look at his operative report, which was from the iliac crest.
And what is a cancellous?
Well, you have two types of bone, and one is cortical, which is the hard bone that we all see, and then inside that bone you have cancellous bone, which is in the medullary canal.
And so
it's
what was
spongy.
And what was the purpose of this plate here?
To stabilize this structural corticocancellous bone graft inside the defect to allow that bone to heal.
Back up to the full picture of 10, MV10. All right, looking at the far right, the post-operative surgery. So you did surgery when on April 14th, 25?
Yes.
And if I'm not mistaken, the X-ray that we're looking at the far right is dated when?
Objection to leading.
I'm asking when is the day of the X-ray on the right side?
So sustained is the first part of the question. Now the second part. Go ahead.
I'll rephrase it, Your Honor. I don't want to. When is the X-ray taken on the right side of this diagram?
Well, according to the diagram, 5 August 2025.
So that's just a couple of months ago?
Correct.
Tell us what we're looking at and what do we see?
What you see is the plate in place and the bone graft, and at that visit, I felt as though there was some evidence of early consolidation or healing. These can take upwards of 6 to 12 months to be completely consolidated.
As we sit here now in October of 25, is that plate still in Abby's hand?
It is.
Do you believe, first of all, do you have any idea as we sit here whether you'll be able to take out that plate and when?
Yes, and I have spoken to her and will probably recommend taking that out within 6 to 8 months. She still has a fair amount of pain over that area, which I think is related to the plate and the screws. So probably within a couple of 3 months, we'll get a CT scan to assess for complete consolidation and then subsequently plan on removing the implants because they are so close to the skin.
Do you believe that Abigail Zwerner's injuries in her hand as a result of this shooting on January 6th are permanent?
Yes.
Do you believe that your testimony and your opinions today are based on a reasonable medical probability?
Yes.
1 second, Your Honor. I have no further questions. I appreciate you giving us your time.
Thank you. Any cross-examination?
Just a few questions. Dr. Stewart, are you aware that during the course of your treatment of Ms. Werner that she's completed a 1-year cosmetology program?
Yes.
And you know she's a licensed cosmetologist in the state of Virginia?
Yes, it's reflected in my notes.
And you don't have any objection to that, Your Honor?
No.
You don't? Thank you.
Any follow-up based on that?
No, Your Honor.
Okay, thank you very much.
Thank you, Doctor. I'm sorry you came this far for that little, but we needed it. Thank you.
It's okay. Thank you very much.
Thank you very much, Doctor. You are excused and released from your subpoena, but I would ask that since this case is still ongoing, you not talk about the case.
Absolutely.
Thank you, sir.
He's released from our subpoena.
All right, very good.
Thank you, Dr. Stewart. Appreciate it.
All right.
A short break before our next witness.
Okay, and that's going to be?
The sister.
Okay. All right, very well.
Thank you, Doc. Appreciate it.
All right, we'll go ahead and take a 10-minute in real-time break, 15-minute in lawyer time break, and we'll be back. Have Deputy Hopkins come get me, all right?
More continuing coverage of the Abby Zwerner civil trial is coming up. Press subscribe now so you don't miss a moment. From the Hidden Killers podcast and True Crime Today,